Hi, and welcome back to MD, PhD, ETC. I'm your host, Dr. Captain Dr. Robert McClay, MD, PhD, ETC, and we're continuing our Intro to Psychiatry lecture series on antipsychotics. So if you haven't seen the earlier introduction on classifying psychosis as a whole, and specific psychiatric diagnoses such as schizophrenia, schizoaffective disorder, etc., I do recommend listening to those first. But on the other hand, if you're just looking to learn why psychiatrists pick a particular antipsychotic medication or want to prescribe one yourself or know a little bit more about it, you can come and jump right in here. So, a little history on the history of antipsychotic medications. So first of all, what is psychosis? Psychosis is a persistent, consistent loss of reality testing. This is most famously associated with the condition of schizophrenia. Most common symptom of that, or most noticeable symptom of that, is hearing voices or hearing sounds, what are called auditory hallucinations. So this is a condition that affects about 1% of the overall population and used to be, actually to some extent still pretty much is, a huge public health crisis. So these days you may see individuals with this condition sort of wandering on the street, often confused, seeming to talk to people who aren't there. It's a horrible condition to have. You can also have psychosis as part of a number of other conditions in which people lose touch with reality. But for hundreds or thousands of years, there really was nothing we could do about it. They used to have these huge public institutions where they just locked people away. And therefore, that's why when the first medication that really treated this was introduced, it was considered one of the great revolutions in medicine. The others being first and foremost hygiene, which allowed surgery and other things to happen, and then probably the introduction of vaccines, then antibiotics, then anesthesia, but then following close on those heels, the introduction of antipsychotic medications has really been revolutionary to modern health, which is far to say from saying that they are perfect drugs. They do not cure the condition. They have some nasty side effects, the specific side effects depending on the type of the one you're taking. And side effects have largely been the way that these medications have been split apart. The very first of these was kind of discovered by accident. That is chlorpromazine, marketed as Thorazine in the United States. And again, it wasn't really intended for antipsychotic purposes to begin with, but ended up having this huge benefit in terms of allowing people who are hearing voices, seeing things, to improve. And we kind of backwards reasoned how schizophrenia worked based on that, because the thing about chlorpromazine, though it does a lot of different things, it's what's called a dirty drug. In other words, it affects a lot of different receptors in the brain. But the main finding was that it blocks a particular type of receptor for the biochemical dopamine, and particularly the type 2 dopamine receptor. It wasn't hugely powerful at doing that, and therefore it was the first of what we now call the low-potency first-generation antipsychotics. Those are ones that it takes a fair amount of the medication to block the receptor enough to be able to actually cause the voices to go away or the psychosis to improve, and also has effects on a number of other receptors which may or may not be beneficial. In particular, chlorpromazine, Thorazine also blocked something called acetylcholine, and therefore actually that ended up blocking some of the side effects that we saw in some of the later ones. But in general, we found that to get this antipsychotic effect, it seemed like you had to block about 80% of the dopamine receptors to get that. And unfortunately, that was dopamine receptors everywhere. And there are 4 main pathways in the brain for dopamine. There are probably other ones, but there are 4 main ones. And the one that we want to block is called the mesolimbic pathway. And what that seems to be associated with hearing voices goes from the mid part of the brain up to a middle area of the sort of upper cortex called the limbic system. And again, when you block that, your antipsychotic symptoms seem to improve. Unfortunately, there are these three other systems, one of which seems to be tied into symptoms of schizophrenia, called the mesocortical system. That is involved with sort of complex thinking, and it's thought to be, the disturbance in that system is thought to be one of the reasons that schizophrenics also have these negative symptoms of schizophrenia. But sometimes blocking it actually even seemed to make it worse. In terms of those negative symptoms, the antipsychotics seem to make people seem very flat, very blunted, seem to almost exaggerate some of those what we call negative symptoms of schizophrenia. And they also clearly block two systems that we understand a lot better, which are the tubulo-infundibular system. That's a system that goes to the pineal gland and regulates the release of the hormone prolactin. The prolactin is a hormone, as it implies, that it encourages breast milk to be developed, but the dopamine actually blocks the release of this in this case. So if you block dopamine, you actually get increased prolactin release. So unfortunately, that can mean that both men and women can start to produce milk or grow their breasts, what's called gynecomastia. It also has negative effects on sex drive and libido. So some unpleasant things there. And then the other one is another disease that has been sort of a scourge of neurology, which is Parkinson's disease in what's called the nigrostriatal pathway. And if you block it in that, so basically we induce a Parkinson's disease-like state with these. So these were all some negative, nasty side effects. And some other long-term side effects that for pathways that are sort of indirectly related are what's called extrapyramidal side effects. The pyramidal tracts are the main nerve fibers that control movement in the body, but there are other pathways that control movement. And when these antipsychotics were in place, some strange movement things happened. Sometimes what are called acute dystonic reactions. In other words, muscles suddenly tensing up all at once. This can be very scary, very unpleasant, especially if it happens to the neck, twist your neck. Very bad things can happen. Long term, it could lead to something called tardive dyskinesia, which is a slow sort of writhing movement, often seen as like lip smacking movements that just didn't go away even when the antipsychotic was stopped. And then also a general motor restlessness called akathisia. So a whole collection of nasty side effects, and that's just from the dopamine, never mind the other things that went along with it. As these drugs progressed, we went from what are called the low-potency antipsychotics to the high-potency antipsychotics. The ultimate example of that is haloperidol, which is still used a lot. It binds very tightly, fairly exclusively to the type 2 dopamine receptor. Unfortunately, it doesn't get rid of any of these dopamine side effects. So other things that might be related, so from the dirty drugs, the older generations, the weak ones, might cause problems on the heart based on other transmitters, cause drooling, some other things. So those sort of went away as the drugs became more specific to dopamine, but it did nothing to help any of these movement disorders. It also did very little, if anything, to help the negative symptoms of schizophrenia, the sort of flat symptoms. Then one drug really revolutionized antipsychotics, and that was Clozapine or Clozaril. Again, sort of an accidental finding, is this drug bound rather weakly to the dopamine receptor. It's still bound there, it still affected it, but it wasn't potent enough. It seemed like it should affect psychosis. But in fact, it turned out to be the most potent antipsychotic that anyone ever found to this day. And that was, good grief, in the late 50s or early 60s, I think even. Anyway, it's been around for, don't quote me on that one, but it's been around for a long, long time. And it's still to this date the most effective antipsychotic, and one of the only ones that really seems to have a profound effect on what we call the negative symptoms. In other words, where someone is sort of in this locked in, can't figure things out state where they're just very flat, can't figure people out, can't sort of realize how impaired they are. So Clozaril can still be quite life-changing. However, if you're not actually a psychiatrist, it's very unlikely that you're ever going to prescribe this because it has a whole collection of very nasty side effects that go along with it. The most concerning is that it can suppress your immune system to the point that it can actually kill you. Now, that is pretty rare, and it does occur with some warning signs that we'll see a certain type of white blood cells called neutrophils start to drop off before that would happen. So people who are on this need to get lab tests every week. You have to crank it up very slowly, so it's not going to be used in sort of the immediate treatment of psychosis. But over time, it can really be life-changing, and despite the fact that we think, oh my goodness, this is a really dangerous drug, it could potentially kill you, it's actually the only medication that's actually been shown to definitively improve lifespan as a whole. People with schizophrenia who are on Clozapine or Clozaril live longer than people who are on any other antipsychotics or no antipsychotics because their overall life is better, and they're able to figure things out, like I shouldn't do dangerous things, I shouldn't kill myself, I maybe should eat right, these things that schizophrenics are often missing. So if we look at sort of the extremes between Clozaril, which is this very unusual, what we call atypical medication, and the first generation and low potency and high potency drugs that were really focused just on dopamine, people tried to figure out, well, can we create something that's kind of in the middle, maybe not as dangerous, but maybe has some benefits in terms of negative symptoms. And this is where the whole, what are now called second generation antipsychotics came along. And the first of those really being Risperidone, or Risperdal is the brand name. And they essentially back engineered Clozapine to figure out what was going on. Now, they never did a great job of that. These newer drugs never turned out to be as good as Clozapine. But the second generation antipsychotics, for the most part, found out that you needed to modulate dopamine instead of just blocking it everywhere, that if we blocked certain other receptors, and the main one was the 5-HT2 or serotonin type 2 receptor, that you could increase dopamine in other areas of the brain that we didn't want to block it, in the nigrostriatal pathway, in the tubuloinfundibular pathway, in the mesocortical pathway, and maybe get some of the more benefits in terms of the negative symptoms and not cause all these movement problems, not cause the prolactin release. Now, Risperidone was still what was called a pseudo-atypical, in that it was still a very potent blocker of dopamine, and based on high doses, it could act very similarly to Haloperidol. Very useful in short-term use, both the Haldol, Thorazine, or Chlorpromazine, give it a very immediate, good antipsychotic effect. Those are often what you'll be seeing in an emergency room. And the advantage of these second generations is they did not seem to cause the movement problems. Based on that, there were other ones that were developed, olanzapine, Zyprexa, quintiapine, Seroquel, Zisprazidone, Ageodon, a number of other new ones. They came along, and they're still developing them. These medications seem to have sort of a broader effect. They also seem to modulate mood, particularly some of the, as we sort of refine them going along, they seem to have antidepressant and anti-manic phases, so it could be used not just to treat the schizophrenia-like symptoms, but also bipolar-like symptoms. So they became much more popular than the older antipsychotics because we could treat different conditions. We didn't have to focus so much on differentiating bipolar disorder from schizoaffective from schizophrenia anymore. They worked on a lot of different things, and they didn't cause these movement problems. But they did come with a whole new collection of problems, which is that they altered metabolism. Basically, people eat too much on this and often get fat even when they're not eating. And it may do something to glucose regulation that's even apart from that, particularly with olanzapine, but also with the older Clozapine drugs, you would see people develop diabetes symptoms. So overall, the side effects may be a bit of a wash. And when the National Institutes of Health did a head-to-head study of basically every antipsychotic versus every other antipsychotic at the time, there are newer ones that came along since then, they expected these new ones to win, and they only included one of the older ones, but it turned out they all were relatively equal in terms of how long people were willing to stay on them and how long it would keep people out of the hospital. So it's, to some extent, pick your poison as far as the side effects, though you do still probably get a broader effect on different conditions with these second-generation antipsychotics. Now, some people have classified another group into the third-generation antipsychotics, and these are ones that also cause, instead of just blocking dopamine, modulate it in some way. Aripiprazole or Abilify was the prototype of that. And these are drugs that are, instead of just binding and blocking the dopamine receptor, both turn it on and off, sort of hold it in the center, what are called partial agonists, drugs that turn the receptor on and off at the same time and hold it in a certain position. And that has advantages, that they also seem to modulate mood. They don't come with as many of the side effects that we typically associate with the earlier ones. For example, these are often not so sedating. All the other ones pretty much knock people out. Sometimes aripiprazole and its children, brexpiprazole, can actually make people more energetic rather than less, but also have the disadvantage that once they've bound to the receptor, there's not much else you can do. They're sort of either they work or they don't. They're generally felt to not be as powerful as the other antipsychotics, but again, they're broad spectrum. They don't have perhaps as many of at least the movement side effects. They've also, the second generations and third generations, have gotten better at not causing diabetes and weight gain. So when a psychiatrist is picking an antipsychotic, first of all, they're probably going to think, am I using it right now? This person is, say, actively screaming at voices, going to take a swing at me, out of control. I need to use something that's very powerful to sedate this patient, and therefore I don't even care if it's a particular messy drug in terms of other receptors. I need them to feel tired, and therefore even old-fashioned chlorpromazine can still be very effective because that drug makes people very tired, and it still works in terms of the psychosis. Let's say they are having very active voices, but they're not sort of out of control. I want to get those under control very fast. I want to get those positive symptoms. You might still use something like haloperidol, block that dopamine very, very fast. And let's say you're not sure that this person looks a little manic-y, a little other things, then often the second generations, risperidone, olanzapine, zisprazidone, quintiapine, are very popular for those purposes. Some of them you can't titrate up as fast, so you can't throw, say, as much quintiapine as someone as maybe you want initially, because it has other side effects that make your blood pressure drop a little bit in that regard. So you're going to be thinking sort of short-term versus long-term. Am I treating one thing? Am I treating multiple things? But overall, we're going to be thinking about blocking dopamine in some way. And then we're going to be thinking about managing the side effects. If we're talking about the older ones, we're going to be talking about looking for these these movement problems, making sure they don't develop this twitchiness, which is directly related to the dose and the time that they're on them. They also can feel uncomfortable if they're not used with another medication to block some of those movement things. And an anticholinergic medication such as diphenhydramine, Benadryl, or benztropine, Cogentin can lower the risk of those movement issues, but then comes with the anticholinergic problems in and of itself. So, sort of a one catch-all drug. You can throw a second generation on there. Sometimes we'll mix that with something else to help somebody feel a little bit more calm in the moment, like a benzodiazepine, like Ativan or Valium. Diazepam is Valium. Lorazepam is Ativan. But any number of benzodiazepines can be mixed in there to help calm someone in the short term, and then longer term, we may try to titrate them on something that has the most tolerability, that's going to both cover their symptoms, and depending on whether they're worried about their metabolism, someone's getting very heavy, you might want to switch back to one of the older ones. Someone is developing some movement issues, you want to move to the new one. They have long intractable symptoms or really severe symptoms, particularly negative symptoms where they're just not understanding things. You might want to switch to Clozapine long term, as that does have the best long-term outcomes, but then you got to get lab tests sort of every week for a long time. Lab tests never go away. Eventually you may not need them every week, but you're going to need them for a long time, and there can be other side effects, risk of seizures, drooling, other things that can be nasty with that, but you really can dramatically improve their quality of life. So there are a whole lot of these drugs. I do not think, unless you're a psychiatrist, even if you are a psychiatrist, you don't need to know all of them. But you should probably know a couple. I would recommend knowing one or two of the short-acting, either high potency first generation antipsychotics or reasonably high potency second generation, so something like haloperidol or risperidone, that can be used very quickly when a patient is agitated. Both of those mix nicely with diphenhydramine Benadryl and lorazepam Ativan to allow a patient to be calm. Haldol also has the advantage that what's sometimes called the 5-250 effect or combination, or B52, which is where you combine 5 milligrams of Haldol, 2 milligrams of Ativan, 50 milligrams of Benadryl, cover a lot of different bases that can be given orally, intramuscularly, or intravenously, get very quick effects in controlling acute psychosis. But then if you're managing someone over time, you want to probably these days think about more about the second generation or the atypicals. And if you've got intractable patients, it's probably really worth passing it on to someone who knows how to manage Clozapine, and that is a medication that requires a little bit more skill, lab testing, a little bit more knowledge in terms of the overall side effects. But that's a quick capsule of antipsychotics. So next time we're going to move on to talking about bipolar disorder. Specifically, we've covered some aspects of that in earlier lectures in terms of psychosis and mood disturbance, but we're going to talk about the long-term condition, and then some other psychiatric disorders and how to treat them as we go along. Hope you keep tuning in. Hope you keep learning. Please leave feedback, comments, and subscribe. If you have other comments, ones that you particularly like in terms of medications or other topics you'd like to see covered, please also let us know. Thanks so much for watching.